Hi, Marvy, can you hear us?
Yeah, he just fine. We've just done a quick sound check on Ansar as well. He's fine.
Okay, great. Super.
How are you
So we're
both?
just going to give it a minute or two for people to log on.
Oh yeah, yeah.
Hey, I just had the thing on. Yeah, I'm joined, but I don't know. I think I'm
Hi, Simone.
no. I was speaking to her about her daughter. If she is still in the hospital. Is she? Shut up.
Hi.
I just texted her this morning and said, "Was he still on how he is?" So she said, I'm on the way to now. They won't let me go in because it's ICU. Oh my God, don't. That's horrific. She must have got that soon. Yeah. So it was the with diabetes, you just said, it's not another one, you. God, after
To save on bandwidth, Barry, I'm going to go turn my video off
Sure,
and
great.
mic off. But let me know if you need anything, and I'll be around.
Absolutely. Um, so I think we might get it moving. Um, so a lot of you may know us. We are Mitron. We're the distributor in Ireland for T Lab Regenerative Medicine. Um, we have a background in fertility healthcare, and this year, 2025, we've launched a range for regenerative products for specifically for aesthetic applications. We've kind of called this meeting just to offer some scientific support on the specifically the autologous exosome product that most of you will be familiar with. So we've drafted in the expertise of Mr. Ansar Mahmood, so we're very pleased that he's able to join us today. Mr. Mahmood is a lead major orthopedic trauma surgeon at the Queen Elizabeth Hospital in Birmingham. He's also sits as the president of the British Trauma Society. He's orthopedic trauma research lead at the Institute of Translational Medicine in the University of Birmingham, with a specific interest in regenerative medicine. So he's the course director at the major incident surgical trauma teams, and he's an educator at the Academy of Regenerative Medicine. He's a founder director at Pinnacle Global Healthcare, which is an orthopedic clinic specifically offering regenerative treatments to patients and stem cell therapies. And as if he had time for all that, he also has been practicing in aesthetics for the last 19 years. So we're very pleased that he's made the time to be with us here today. So thanks, Mr. Mahmood.
Thank you. Thank you, man.
So just as we're going to go through with a lecture style or a talk given by Mr. Mahmood, and then there'll be time for questions and answers at the end. If you have any questions, feel free to pop them into the chat box and they will be addressed at the end.
But why? I don't understand, you know, I don't understand. Why does that work, you know? It seems to be. Are you fine?
Can you see my screen, guys?
Yeah, I can see it now. Thanks.
Yeah, no worries. So I'm going to do a quick overview on exosomes in regenerative medicine. As Barry said there, I'm a bit of a stem cell sort of PRP geek, and I have been for a good 15 years or so, and have been playing around with optimizing those for quite a long time. So we're going to talk about exosomes today, why we're interested in them, what we think they do, and then just hopefully answer your questions, and not answer the questions. I want to the most important thing, probably learning objective to go away from this, is what we don't know. There's quite a lot that we don't know about regenerative medicine yet. We're getting better at it, and it's a very, very promising area. But there are unknowns in the space, which I'm sure you've come across. So exosomes are basically small delivery vehicles. In the 80s, when that phrase was first coined, these were actually seen as exhaust fumes of cells. They were seen as the actual waste product and waste material that cells produce. So people ignored them for like a good decade, where they thought actually this is just junk, cell junk. But later on started to realize that actually when the technology caught up and using both flow cytometry and cell analytics, started to realize that these bits of cell junk actually bound to the cell, often attached to the wall, and release little packets of signals that actually cross the cell entirely and will exchange RNA and DNA with the cell nucleus. So it then became really interesting to evaluate what the capabilities of them were, and to some extent, when it comes to cellular health and cellular optimization, their capabilities are infinite, because they are what generates all of the signal and interactions of the cell. The cell itself may be limited. The human and biology that they're in is also limited. So, you can't always get the signal you want, but they have that capability. They're incredibly small, and that's one of the ways they're defined. You can see the size there, 30 to 150 nanometers when they measured. And that actually is, there are different types of the secretome that cells make, and there are different places we get them from. The classic exosome that everybody's sort of familiar with is what comes from a stem cell. So the reason a stem cell works is it goes into an environment, it reads that environment, it picks up a problem, and the cell wall has receptors on it, and those receptors create read the environment, and they pick up a problem, and then they produce a secretome that is specific to that problem. And that's how they differ from PRP, because PRP is more of a kamikaze pilot who responds to a signal, and it doesn't have the intelligence of a nucleus, a platelet. So they only have one response, which is bind together, aggregate, activate, degranulate, and they just release everything that they're carrying in one go into the environment. The environment then, the cells in that area will pick up the bits of signal that they need or want from the PRP, and we know all of the potential benefits that PRP gives for skin, for hair, You know, I teach on that space for about 10, more than 10 years now, and our background when I first did a study on PRP was actually in burns patients, and we found that if we actually spray painted burns patients, it sounds a little bit crude, but we actually aerosoled it in a polysaccharide vehicle, and we sprayed PRP onto burns, and we actually found that the graft take was 25% higher. And we also found that the bed for grafting was ready 2 days earlier. So you can actually graft earlier and the take was higher. So there's some really interesting things that we know PRP has a capability to do in skin as well as wound healing. You know, we use it in wounds, and off the back of that is when I sort of started learning about its use in aesthetics about 12 years ago. I've been doing aesthetics since I was a junior registrar, so as you said, about 19 years ago. But yeah, fillers and Botox, like most people, I suspect, early on, and then very heavily into the regenerative side for the last, say, 10 years at least. So we've got different types of exosomes, and again, I don't want to bore you too much about this, but you know, you can see that most of the ones on the market are plant derived currently, and my view on that is that we're using those because of licensing. It's that simple. If we were actually allowed to use the exosomes we want to use, there would be human-derived exosomes. Nobody would choose plants unless, you know, you've got a philosophical issue with it, because you're not going to get the same extent or potency of signaling usually from plant EVs as you would do from human-derived. And then the next question is, well, but human-derived are not allowed to be injected, for instance, or need to be done topically. And the human-derived in the European market and UK are not allowed to be injected or used in most areas of medicine yet because of concerns around risk. In the Far East and other parts of the world where I lecture and work, there is actually quite wide use of them, with showing good efficacy, good data, good safety data, but that's not the licensing currently. So in the aesthetic sector, they're predominantly plant derived. There's a few hybrisomes from animal and xeno formats, and then the new promising thing was, well, actually, if you harness the exosomes from platelets and utilize those, they're autologous. We already know they generally generate a positive response, and you may be able to get the harness the effect of PRP in a more enhanced way and earlier. So the way exosomes deliver, there's a four-step process. They form multivesicular bodies. Well, they're formed from multivesicular bodies that produce endosomes. Again, I don't want to labor too much on the actual cell side of it, but there's two primary ways they actually get into cells and perform their action. One is they bind to the cell wall and send signals in from a distance. The other is they traverse the cell wall and then actually go directly into a nucleus and exchange direct RNA, microRNA, long coding RNA signals, and exchange those with cells. We're interested today. I mean, I suppose most of my talks in this space, probably 80% of them, tend to focus around orthopedic and sports injuries, but we're going to talk about aesthetics today. I do a lot of PRP and hair and facial PRP lecturing, and have done for about 10 years. So we understand the space pretty well. And what we're looking for is a standard skin rejuvenation responses, which is a better cell turnover, healthier fibroblasts, more mitochondrial function, which increases cell turnover. That gives us a reversal of the clock with thicker skin, more elastic skin, more collagenesis, and the normalization of the tissue remodeling pathway. So it's one of the few treatments that actually turns the clock back on the skin. Most of the other modalities that we use in aesthetics that create collagenesis, for instance, or thickening of skin, do it by generating abnormal ratios of collagen. So you actually end up with too much, you know, for instance, type 4, type 7 collagen. You do get collagenesis as the companies teach you, but it's not the collagenesis you actually want. It's not the collagen that forms skin in the right balance. So what you actually end up with a lot of modalities in aesthetics, you actually end up with fibrosis as the response, and that's what they call collagenesis, because fibrosis is a collagenesis response. But over time, that leads to skin hardening and alterations in the way the skin handles, looks, etc. And that's one of the reasons that got me into regenerative medicine in the aesthetic sphere, because I saw what I did to my own patients over about 10 years of aesthetics, where they came back with hard, shiny skin that I couldn't move, and I was tunneling cannulas through, and they were crunching as they went through. And I thought, wow, the amount of fibrosis we've generated by doing biostimulators and Elance and fillers that we've done, annually for patients, it was an issue. So when it comes to hair treatments, hair is a different beast to skin. You're dealing with a follicle, you're dealing with stem cell upregulation from the bulge area. And so the technique is important, but also our experience with PRP has been that the signal required to generate a response in hair is much higher. You need a higher concentration of growth factors, a higher concentration of signals. And the best studies, if you evaluate the studies by dose, you're looking at usually about 4 to 5-fold concentration as a minimum of your baseline from your patient's PRP concentration, platelet concentration, to generate a decent response in hair. Lower concentrations will generate a response in 60, 70% of patients, but you then start to fall into that category of like, well, there's no guarantee of result for any of our patients, but if you do a high concentration, you'll find 80, 90% satisfactory results. Whereas if you're sitting down about the 60% mark, it's almost like flipping a coin, isn't it? You're not sure which one is going to work for, which one it isn't. So we know there is a dose-related response. The primary effect that studies have shown that we generate is anti-inflammatory, upregulation of stem cells, and virtually all growth factors that go in and affect hair. Fundamentally, most of their action, whether they're working on the wing beta-catenin systems, etc., they increase the anagen phase of hair growth. So you end up your hair growing and being sustained for longer. And the thing I say to my patients when they come to us for hair treatments is that the first thing you will notice is that you're shedding less hair. So you'll lose less hair, and they'll notice that within usually 6 weeks to 12 weeks that they're losing less hair. Obviously, the longer term effect, when you look at the growth cycle, which is between 2 and 6 years, it takes quite a long time. So it may be 6 months or 12 months before they see thickening of hair. Although I've got patients who do, promise us they've got improvement by 3 months. And when you look at the studies, you do see that there is some improvement in trichograms at 3 months, but it's relatively minimal. Most of that happens at 6 to 12 months or beyond. But then the effect wears off, and so you've got to try and keep them going, because if it's androgenetic alopecia you're dealing with, it's gonna the DHA response and the dihydrotestosterone DHT response will return and carry on causing problems. This is a study, a nice study where it combined exosomes with and without laser, with or without microneedling. And it actually had a group of patients that just had the standard intervention, the laser or the microneedling, and it had patients who were then added exosomes were given to them, and it actually showed almost a doubling in some cases, but around a 30-40% improvement in the exosome group. So it showed that when you added exosomes to your standard of care, you were actually getting a better response. So we know that that there is promise in the treatment of exosomes. Platelet-derived exosomes. This is actually a study that came out of Mayo Clinic, where they actually, this is wonderful. The reason I pull this up is because it's important to the message I'm going to deliver, which is dose. In Mayo, they actually standardized a dose. They actually said that they made platelets, they lyophilized them. They made platelet-derived exosomes. They lyophilized the exosomes so that they had a fixed dose per volume they were giving. And they put it into a cream, and they got the patients to put it onto their faces for 6 weeks, and actually found that there was a 40% reduction in senescent cells, upregulation of other parameters, and pretty much 95 or 98% of the patients showed skin improvement. So we'll go into, like I said, the dosing side of this in a little bit more detail. And I am going to extrapolate a little bit from PRP. The traditional PRP treatments are very dose dependent. And I published a paper with my colleagues from America and Brazil and Japan in 2023 showing that certainly for orthopedic and muscle conditions, the dose was vital. For hair, we know there's also a dose-related response. For skin improvement, if it's just for rejuvenation, you're less dependent. Fibroblasts often do respond in any event, with say even a 1.5 or twofold increase in concentration, they tend to respond, especially if you're doing synergistic treatments like microneedling, etc. So it's we know depending on the tissue you're dealing with or the pathology you're dealing with, you can generate a really good response with PRP. So why are we interested in exosomes? One of the reasons we're interested in exosomes is the promise of exosomes was that you can bypass some of the activation steps that PRP or stem cells go through and get to the end product that bit quicker. And if you can concentrate that end product, the growth factor response delivered by the exosomes, and deliver that to the end tissue at a measurable, viable dose, you may actually generate the effect sooner, and you may generate an enhanced effect, is the promise. The reality is that, and this is where the caveat is, nobody has compared these things clearly to the standard of care. So I'm not aware of any study currently that is clearly evaluating exosome dose to PRP dose direct head-to-head. There was a really nice publication on fertility, actually, from South America this year. And this is a fertility clinic that's been using PRP for 15 years for fertility, and then started using exosomes from PRP. And there's a few things they found. One is they found their live birth rate was higher. It didn't actually meet statistical significance of birth rate, but what they did also do is they did biopsies on the ovaries, and they found there was less fibrosis and higher follicular viability when measuring using the exosome product versus the PRP they had been using. And they were using the same PRP to make the exosomal product. So the PRP they would use ordinarily to drive the ovaries, and this is intra-ovarian, they were using that same PRP to make the exosomal product, and we're finding the exosomal product in their view was a bit cleaner because it generates less fibrosis. And that sort of makes sense because with platelets, when they activate, they generate a pro-inflammatory response, which can go on. Your growth factors peak at about day 3, stay high for anywhere between day 7 to 14, depending on the tissue you're injecting them in. And during that early phase, that first 3 to 7 days, the effect can be quite pro-inflammatory. That pro-inflammatory will generate a degree of fibrosis, scarring, other downstream effects. Even in skin, it will just do it much less so than biostimulators and say high energy radiofrequency treatments or laser. So it's beneficial, but it still generates a minor degree of fibrosis and a pro-inflammatory response. And that's why we leave intervals between the treatments, because if you attack somebody's skin weekly with PRP injected with needles, you generate too much stimulation, and the skin gets overwhelmed. And we know it actually not only plateaus, but it drops the response it's actually going to deliver. So you actually get a reduced effect by overstimulating. And the exosomal group generate less fibrosis. It doesn't have, I think, that higher peak of fibrosis that is extended over days. I think the switch over to anti-inflammatory and anabolic regeneration happens earlier because you're already at the end point of the platelet product. Hope that makes sense. So again, studies looking at hair growth outcomes. Again, there's only 5 in the literature I'm aware of, specifically for hair. All of them show positive results. The question is, there is a significant variation, and again, we're comparing apples with oranges because the dose between the exosomal PRP delivery, the way it was delivered, combined with microneedling or laser, was all different. So we're not comparing like for like in any of these, and one of them was actually just a topical application. So dosage, as I said, I was going to go into this a little bit more detail. So the Mayo study quantified their dosing. They actually said that You know, we know exactly how many EVs we have created for the pet by patient, and that's what's being delivered into their skin. And they measured it as a mass of protein that met the 30 to 150 nanometer definition of a EV of an exosome, and so they're delivering about 1 billion EVs per microgram of product, and there's about 1 microgram per mil, so per mil of cream. The obviously this is a topical application, so you're doing it 6 weeks, slow release, steady on a daily basis for 6 weeks, and it showed a positive response. When you're going to inject these things, my own experience, I think I used the first PRP exosome kits in the UK. Is the first couple I used, I was slightly underwhelmed, and I've been told that you've had a similar response. And part of that was, I think, dose related, because I suddenly found I was going from a very high quality, high dose PRP system that I was using, then shifting to a protocol where I was using less plasma, less platelets, potentially to generate an exosome, which I was told would generate, it sort of made sense that it would generate a earlier or a cleaner signal and a better signal to the end tissue. But I was always slightly concerned that we weren't going to achieve the same dose response that we would get, and there was almost certainly going to be a dose-related response. And so I had a mixed view with the first couple of treatments I did, because I had some really good, I had a couple of good results, and then I had a couple of, I didn't notice any effect kind of results. So I then looked into this a little bit more, and we've now started, if we're using PRP and using it to generate exosomes, we're using more PRP substrate, and we're generating a much higher dose. So I think when I'm going to go into this a little bit, because I've seen the later detail that, I think T-Lab have realized this as well now, and I'll go into why they've realized it. So different ways of applying it is also very important. If you're applying it topically using a microneedling, or you're injecting it, you're delivering a very different dose to the tissues, and that's also needs to be understood. So the technique for delivery, but in the Q&A bit at the end, you can tell me what you're actually doing. There are, I'm not going to go into all the challenges around stem cells in the future and exosomes, but there is definitely, the bottom part of that slide says evidence gap, and the evidence gap is still large. We have not got comparative trials comparing these exosomes to other treatments, and so we're using them on a little bit of a little bit with the eye of faith, and we need to go beyond that, because ultimately, as the clinicians that deliver the treatment to the patient, we need to be certain that we're actually doing something that is good for them and is going to generate a definite positive response. And it's not about positive response. You'll always generally get a positive response. If you measure inflammation, if you measure cell turnover, if you measure the effect, you'll get a positive response. But it may not be the response that the patient is expecting. And patient expectation is everything, particularly when you're doing aesthetic medicine. So this is T-Lab's own data, which is from a talk that Timo is one of the inventors and the owner of the company did. And this is just showing you the nanovesicles of the relevant size in PRP. This is how when they then produced the exosome response, and the important figures here are just to look at the number of relevant size nanovesicles, most of which will be exosomes. Not all of them will be, but most of them will be. Probably around an 80% of those will be, and that's 3 billion per mil of product. I'm going to shrink that. It's 3 billion per mil of product, and that was their sort of first go, and they were producing 15 billion EVs in a 5 mil plasma solution. When I was shown this, that already concerned me slightly, because that's lower than I'm used to with what we've produced in our own data in the past. Examine came along and produced this response, so that was a slightly more intelligent way of squeezing as much out of the platelets as you can, using that special ribbed technique and then the centrifugation protocol that the machine does for you. And again, they showed that they could enhance that EV delivery to, by a significant amount. It's jumped up tenfold to 43 billion EVs per mil, which gives you, over 200 billion in an average 5 mil injectable. That's more promising. That's still quite low compared to what I've been using, say, in orthopedics, where in ortho we tend to aim for 1 trillion per mil if we can achieve that, because we've noticed an increased response from that, and that's just anecdotal because we've tried it in 20, 30, 40 patients, but it makes sense, I think, when you compare the total potency of potential platelets that we give. And so, for instance, in orthopedics, we tend to aim for 10 billion platelets. And if you shift that not just from platelets, but into, say, leukocyte-rich PRP, because when you spin PRP, you generate a column of blood, and what you'll find is that the platelets stack up in that column. If you just take yellow plasma without the buffy coat, you will lose your largest, most potent platelets that are probably the most growth factor rich. So we've started to now in more circumstances take the buffy coat layer. You'll also then find, depending on the centrifugation protocol, that actually the upper layer of the red cells also has some of those very large platelets in. So you end up taking that and almost trying to do a double spin. And we found that growth factor concentrates are much higher. They're much higher, like almost a double or tripling of just having a really high platelet concentrate that looks golden with plasma. If you go for leukocyte rich, you include the buffy coat layer and even maybe 0.5 mil to 1 mil of the red cell layer. But it usually means that you'd end up having to do a double spin to get the product a little bit cleaner before you inject it into a face or into a knee as you needed. So this is the relevant slide for you now because this is what's changed. So from Exomine, T-Lab have now produced what they're calling a product called ExoMass. And this is what they've done effectively in very simple terms. They've included the buffy coat layer and the upper layer of red cells to enhance the total growth factor concentrate and ensure they get all of the platelets, including those big platelets and the leukocytes and the neutrophils. And if you then take those through a centrifugation protocol to collect as many EVs as possible, the exosomes as possible, they're now reaching thresholds where it's 1.5 trillion. So this is not 10 to the 9 anymore, it's 10 to the 12. So that's 1.5 trillion per mil. So, and you're now getting 8 mils of plasma, which will generate a total dose that's given to you in your hands of 12 trillion exosomes. And that's a multiples of the 200 billion you were getting before, many levels above that. So, it's something to, I'm glad they did this because, as I said, it was the feedback that I gave back to Timor that I was worried about the dose-related response. PRP has been shown to be dose-related. Leukocyte-rich tends to generate a higher growth factor response. And this is not a game of platelets, it's a game of growth factors. And you could argue that within the growth factors, probably the most important population is the EVs and the signal they ultimately end up delivering. So we've now got a 56-fold concentration compared to Exomine using the ExoMass product. And I think that's going to be an important game changer. And this just shows you the protocol. Barry and the team in Ireland can share this with you because they'll have it already available. I'm assuming, but I'm not 100% sure. But I'm not going to bore you by watching the video of it being prepared. We can discuss it if you want to, but you can see here there's the step in the middle here where you can see they've taken the buffy coat layer. That's what the red syringe is. So that's your standard PPP or PRP layer that you would take. And they've got the four vials, 40 mils of the whole blood has been extracted to make the PRP fraction. This is the buffy coat. So this is the layer with the really rich rich platelets, the larger ones, leukocytes, neutrophils, all sitting in that layer. And that's what's giving this the boost, because they then blend these two together and they produce an end product, which they then spin down, and it gives you far more clean. It's still a clean product, but it gives you far more EVs. Well, we're in aesthetics, so we like a good before and after. And this is a single treatment. This is not my clinic. This is from a Turkish clinic, Dr. Irem Dogan, who's being shown there. And this is 3 months downstream. And obviously, I mean, I always slightly worry about before and afters in aesthetics or anything, because even myself, I've got patients who are skiing 3 months after a major knee injury. But we know that doesn't happen to everybody, right? That everyone picks their very best patients and puts them out and puts their pictures out. They don't put, every single patient they've treated. They just pick their best cases and put them out in the literature. For me, the elephant in the room is the patient. The one thing we're not factoring in when we're probably managing patient expectation is that the patient's biology matters, their platelet count matters, the dose they're going to give you matters. If you actually analyze patients' platelet counts and whole blood counts beforehand, it gives you a clue. When it comes to MPV, which is probably a factor most people ignore, which is the mean platelet volume, that actually tells you that the number of platelets and the quantity of platelets available to you. This is where you start to you start to then be able to work out, not entirely mathematically without measuring it. You'd have to do flow cytometry or nanoparticle extraction and assessment. But if you've got a high MPV in a patient and a decent platelet count, you know that you're going to get a good PRP, and that's a decent surrogate for generating good exosomes. You don't know how their biology is going to respond to this. And that's what the elephant in the room is, because what you're ultimately trying to do here is stimulate patient biology. If the patient's inflammasome is not under control, if they are eating, drinking, smoking, things that create inflammation, that damage their hair follicles, that accelerate the signs of aging, and that might just be endurance exercise, right? So, there may be people who are super addicted to running 100 miles a day or cycling 50 miles a day on a weekend. Those sort of people will generate a higher degree of inflammatory. It may be decent for their cardiovascular health, but it's not good for their aging. And so you've always got to balance the biology against what you can get from the patient, and then try and have strategies to pre-optimize and post-optimize your patients. So the patient is always the elephant in the room that needs to be factored into all of this. And that's where the 20% non-responder rates in all the studies that we see consistently, whether it's orthopedics or aesthetics, that's going to be down to patient genetics, biology, and the inflammasome of that individual patient. And that's a bit that we all sort of ignore to some extent. But that's why you will see patients that have no response sometimes, even if you use the very best, EV technology or PRP technology. So in the future, I think we will have standardized methodologies for making these. We don't have that at the moment. There's about 4 companies on the market producing PRP-derived autologous point-of-care exosomes. And you can see that their dosing, their preparation techniques are all wildly different. And people haven't yet done any studies comparing any of those to each other. So the future of this space to me is big data. It's actually everybody collecting data, everybody analyzing their data, and seeing what works for patients. It's not randomized controlled trials. I mean, in regenerative medicine, randomized controlled trials to some extent are dead. They take 2 to 5 years to deliver results. They're very expensive to do. And if they're well powered, they take quite a long time to generate enough patients. And the world is moving so quickly. Even myself, I change PRP protocol every 3 to 6 months because I'm teaching and working in this place globally. And so we're always adapting what we're doing for different areas. How do you do an RCT in this space? It's really, really challenging. But if you collect the data and outcomes of every single patient, and what you did to them and what you gave them and what their baseline was, and then you see what the outcome was, you're going to, over time, if all of us are doing that, thousands of doctors globally inputting data into a registry, we will start to learn what works, what doesn't work, what works for a female who's over 40 and what works for a male under 40 may be completely different, even for the same condition. So that's where the future of this space is big data collection into large registries and everybody sharing their experience and then learning from each other with prospectively collected data. And that, with AI integration, you'll start to pick up signals and signs of what's positive and negative very quickly. So in summary, the exosomes are hugely promising. I mean, every aspect and every part of we published a paper in 2024 with cartilage regeneration and exosomes. We do not know what we're doing yet, but all of the evidence suggests that once we keep learning, and as we keep learning, the results are getting better and better. We're producing more personalized and precision approaches. Dose is important. But you do also have to understand that each patient will be different, their biological response will be different, and the tissue you're treating will be different. Skin and hair may need a different signal. I already put at least double the dose I put in for facial rejuvenation into hair treatments. I usually aim for more than double. I mean, I'm usually going for 3-4-fold increase of what I would use on a face with microneedling, for instance. And again, combining with treatments like microneedling, etc., are also important, or pico lasers if you have them. Yeah, we're happy to have a Q&A. And unfortunately, although we'd like to be this guy and maybe this person be our teacher and say this is the way to do everything, both in aesthetics and regenerative science, there's a degree of the unknown. We are innovating, and our patients are sharing that innovation journey with us. When I consult a patient, I actually do say to them, what I am doing, I've done 4,000 cases of, say, knee arthritis with regenerative medicine. And I said, what I'm doing to you is still my best guess, because your biology and all the variables in between cannot guarantee a result, because what your cells generate and the way your cells respond to it, only you and your maker know how to really enhance that to the level that it needs to be understood. We as individuals can't really understand that to the level we would like to. And so, to me, patient expectation management is everything. And I say to them, this is what we know, this is what we don't know, this is what we're hoping for, this is what the literature shows. And I go through all of that, and I still say to them, even though I'm probably the most experienced PRP guesser in the country, I'm still guessing. It's just somebody who's done 4,000 cases might be able to guess better what works for you. And I do individualized treatments. If we've got a patient with a higher risk, poorer cell substrate, they've got comorbidities, they're older, their platelet counts are lower. You can mitigate for that. I mean, I still consent them and say, because of all those reasons, your response may be lower and not quite as good as a 20-year-old fit and well person. However, there are things I can do, which is I can increase your platelet dose. I can activate it either with autologous thrombin, or I can use a calcium activator if I'm worried about the release state, or I can actually combine it with other treatments that might enhance the outcome. So there are ways of actually both managing your patients, but also mitigating for patients if you're expecting a poorer response in that particular patient, and also pre-optimization of your patient. You're looking at their diet, looking at their supplementation, doing bloods to analyze their micronutrient profiles. All these things are potentially very important. And commercially, from a clinical perspective, actually makes sense as well, because you've got another income stream where you're not only helping your patient better, but you're actually being paid to help them better if they can afford that. So I think those are sort of my a summary of my sort of understanding of this space. There's a lot to learn, a lot to evolve, and I think I'll open it to the floor now, and if you've got questions, happy to take them. I can see Patrick is on.
Thanks, Mr. Mahmood. Thanks for your expert insights. I think there was just one question that came in the chat window during your lecture. So that was with autologous exosomes. Can we inject them into the patient? That's I think one of your slides had addressed the safety of the product with the autologous exosomes. Just if you want to speak to that for a minute.
Yeah, so I think from a the my understanding with regulation, the European Medicines Agency said that they didn't want well, human exosomes, they allergenic, so not your own allergenic exosomes are they don't want you treated with. If you're using a hybridosome or a plant derived, then you can use them topically, not injectably. The concern around exome really is it's the same as stem cells, right? The stem cells, they worry about stem cells creating teratomas or engrafting or growing. If you look at all of the research pretty much that we know of, engraftment is almost non-existent, particularly for allergenic. So actually, if you're using somebody else's cells, they don't tend to bed into your cells. We've got research, for instance, where we've done 20 years of research on cartilage regeneration in knees. And some of those patients have come back and we've actually biopsied the knees, both animal studies and human studies, where we've biopsied the knees when we've engrafted allergenic, so somebody else's cartilage stem cells into somebody else's knee. When you take biopsies of those cells 1 year, 2 years, 3 years later, you find nothing but native DNA. So you do not find any DNA belonging to the donor in that graft site anymore, both in animal and human studies. And that's been shown pretty conclusively. So what tends to, the primary way that they generate a response is paracrine, immune modulatory. They reprogram your own cells to behave differently. Whatever they lay down, the allergenic cells tend to disappear. However, the regulators are still worried. And the issue with exosomes is, again, it's not likely that they're going to create a cancer because they're not a cell. They don't duplicate and replicate and make cancers. But if you have abnormal cells in the area that you're injecting, they could, in theory, enhance the turnover by giving those cells a bit more energy, a bit more of a boost. They could accelerate a tumorigenic response. And that's what they're worried about. Most of their worries, in my view, are completely unfounded and are not scientifically based. Because if you look at the studies, and I think we need a big regulatory shift in this environment, but it's going to take sort of a lot of doctors and a lot of people doing a lot of decent quality research showing this ultimately. And you can see the regulatory environment in places like Japan, Korea. It's not lax over there. When you travel there, you tend to get the impression, oh, well, they let anybody do anything over there. And you actually find they don't. They're actually quite strict. But what they ask for is a safety profile study. If the safety study and the precedent data show that it's safe, what they don't worry about is efficacy. And that's where they are different. So they don't stunt innovation by saying you must prove it works reliably in whatever 100% of patients or 90% of patients. They just say if you can prove that what you've produced is safe, it makes sense, scientific sense and basis. If you can clear that off, you can start to use it in patients as long as you monitor what you're doing. So you have to be able to record. So in places like Malaysia, I've got friends in Malaysia, Japan doing stem cell treatments, allergenic, exosomal treatments, but it's mandated. What I said earlier is to collect data. They've got registries in their own clinics of thousands of patients with all the outcome data, and that's what protects them. And if everybody asks them questions, it's hugely powerful data. And that's the kind of data I want to pull globally from all those clinics into one center. And that will really give us power and value. And that's where the regulators' arguments can be put to bed. The problem is everyone's working in silos doing their own thing at the moment. And there isn't a global body that's bringing that data together. So I hope that answers the question, but I'm not sure it did.
Yeah, great. Thanks. Yeah. There's just a question there in the window about Examine as a product will be off the market and replaced with a new one. And that's kind of for us, I suppose. The question is, as Mr. Mahmood has been stressing for his lecture, the dose is very important. So why offer a patient a lower dose when there's a new product available? So It's looking like as time progresses, there will be updates to protocols. And currently the new protocol is offering the optimal exosome dose. So we'll be transitioning to that over the next number of weeks and months.
I mean, I think
Are there
it
any other
comes
questions
down
from the?
to,
Sorry,
sorry,
sir.
Barry, I was going to say it comes down to your indication again. If you're dealing with, say, facial rejuvenation, I suspect Examine with, say, microneedling is absolutely fine. But I think if you're dealing with hair, my personal view is that you're going to need the higher dose product. Probably. And again, that will be patient specific. If you've got a younger, healthy patient, good substrate, high quality cells, you'll probably find Examine with microneedling for hair will work absolutely fine. But those slightly more challenging patients, older patients, etc., with low platelet volumes, on their MPV and their platelet counts, I think they're going to be more of a challenge for you because you're not going to get enough to generate the effect you're after, and that's where I think the caution has to be in the patient selection, really.
With facial PRP, do you prefer to microneedle or inject?
Inject, simple.
Great.
Because if you microneedle, you get a good response with microneedling. If you microneedle and use PRP, you actually do get a good response. So it's not that it doesn't work; it works well. But you'll lose at least 50%, if not 70% of your growth factors if you're using them topically versus if you inject it.
So there's a question there. Just back from Regenerative Medicine Conference in Windsor this morning. Should we look again at red light with exosomes in terms of signal amplification, exosome absorption, and mitochondria function, etc.?
Simple answer, yes. I use it. And photo activation, enhancement of results. I mean, I think in the regenerative medicine space, we've been discussing this for years. If you really want results, you've got to learn to stack your treatments. It's optimizing your patient, right supplements, right boosters like photobiomodulation, whether it's laser, LED phototherapy. You stack. So in my clinic, if we do PRP on someone, we put them under red light therapy afterwards. We have a device, and we also use a growth factor sterile skin mask, which calms everything down quicker. And it's usually by the time they leave the clinic, all their redness and discomfort is gone half an hour later. And I think, and you're seeing this in all of the very experienced clinics. I was in Florida recently with a friend, and they actually precondition the PRP. So they use, they're putting red light certain wavelengths onto PRP before they inject it, because it actually upregulates the secretome of the PRP. So you can actually enhance your PRP effects by putting it through certain preconditioning modalities, and we do the same with stem cells. With stem cells, we enhance them by red light therapy, shockwave therapy, enhances stem cell function. So people are learning to do this, but not well enough yet.
So that there's another question in the chat window there for how long prior to injecting. I assume you're applying red light therapy after injecting.
Yeah, I mean, I don't see any problem with doing it beforehand either, but it's just again the convenience for the patient, isn't it? I mean, will they come in for a pre-treatment regime? I actually now, if I've got a compromised patient, I don't usually treat for orthopedics on the day of them attending anyway. So they're going to come back a couple of weeks later. So we have like anti-inflammatory diets we put people on. So we check blood profiles if they'll let us, and then we'll pay for it. We'll optimize their nutrition, and that includes novel things like sublingual NAD plus MNN to boost mitochondrial function, and it can be for a short period. We've shown that with just a 2-week optimization, you can enhance the platelet growth factors by 30-40%. It doesn't take long to enhance them. And if they stick with that in the post-treatment phase, I normally say to them, look, you just need to behave for about 4 weeks. What that interestingly translates into for a lot of patients is that because they've actually done well for 4 weeks, a lot of them actually change lifestyle. They'll stick with it. They'll stick with that program, and
Yeah.
and that can be a really important lifestyle change for them. Because I've noticed patients in my own population that hadn't realized what was triggering their joint pain, for instance. And because we put them on an anti-inflammatory diet for 4 weeks, everything seemed to get better. We then treated them, and then when they started eating their normal diet, the joint pain comes back. And they realize very clearly then that it's the food that's triggering their problem, and they've just never realized they've never been off it for 4 weeks or 6 weeks before. And there's an awful lot of people, we do nutrigenomic, genetic, epigenetic testing in clinic for that reason. I've put bodybuilders who are fit as hell, they're enormous guys, off strawberries because I found that actually they don't process strawberry proteins, and they were munching through, a punnet of strawberries a day, because obviously it's supposed to be very healthy for you, but it may not be healthy for you as an individual because your body doesn't process the protein from strawberry. And that was a very interesting epigenetic story I had last year that I've mentioned at conferences, that sometimes you're doing things that you even think are healthy for you and you're ultra healthy. And yeah, I mean, bodybuilders may not be the epitome of health because they actually take all sorts of garbage that makes them enormous, but because they're competing. But they look like they're in prime health a lot of the time. But it is interesting. Nutrigenomics is really important. And that will also govern how your biology responds as well.
Yeah.
You've got to stack the biological signals.
There's another question in the chat there. For skin treatments, would exosome PRP give the same results as 3 to 4 sessions on normal PRP?
Well,
So
I think I alluded to that in the talk, that we don't know until we have comparative studies. So what we actually need to do is be doing like a validated measure, using something like the general aesthetic improvement scale within clinics. You can answer that question yourself eventually once you've
yeah,
treated 30, 40 patients with 3 sessions of PRP, which you may already have, and then do the same with exosome. The answer is going to be yes for some of them,
yeah,
and it won't be for others. And what I say to patients when I'm treating with this is, we're hoping for a higher potential response, but we don't know if that's going to happen for you. So you may still need a repeat treatment. And I just give them a figure. I say, based on how good I think they growth factor responses are. And you have to remember, my clinic's slightly weird because we have the capabilities of analyzing blood, and I have a university lab that plays around with PRP. So I've tested all these products before, so I sort of know what we make in clinic. And I've learned how to manipulate it, so I can change doses and I can increase concentrations. And
yeah,
I don't have any problems, for instance, doing 8 vials or 10 vials of PRP. If I had the
yeah.
T-Lab tubes, I would use 8 or 10 without any hesitation. Use 80 mils or 100 mils of blood if that's what I need.
Mm. So I suppose the key takeaway message is the importance of the consultation, really.
Always is, isn't it? Unfortunately, because it
Mm.
does come back to, I mean, if you manage your patients' expectations, I've got patients who I have not helped, but because I was honest and open and clear with them, they still refer all their relatives and friends to me because they're like, medicine is a trust game. If people trust you, you've always been honest with them, you've managed their expectations really well, you can fail to deliver a result for them and they still like you and still send their friends to you.
Yeah,
And that's always surprised me. I've got a local personal trainer at the gym and still sends all of her customers to me, even though I couldn't help her. She ended up having to go and have surgery eventually. I tried 2 or 3 different things and ultimately couldn't help her with her arthritis pain, and just and I could have carried on, but eventually I just said to her, look, I think you just need to go and have a hip replacement. And you were too high demand. She was in the gym 6 to 8 hours a day. And I just said to her, I don't think a simple regenerative treatment is going to get you back to that level of activity. You just need to have a hip replacement.
mm,
And she, as I said, I've treated a mother, a sister, and 4 or 5 of her personal training customers since then. So even though I couldn't help her, she still sends patients to me because I obviously met her expectations and was honest with her all the way through the process.
very good.
I've seen some other questions now in the chat. All my clients have been males over 42. I've not seen any change. Kieran, I suspect that's a dose-related response. I think currently we may be slightly underdosing them for hair if you're using the standard examine protocol. But that will apply. So, for instance, if there were 25, 30 and had early hair loss with good, normal hormonal levels and good health, they may have responded slightly better. But I think, that's the only thing I can say about that. I don't know how many of those clients you're talking about. Is it 20 or 30, or is it 2 or 3? But it's difficult to know specifically how well it's going to respond. And I don't think currently I don't know. I mean, there's nothing to compare to. There isn't any trials comparing examine to PRP. You can see some of those pictures that I showed you were of a single examine treatment, and they had good results. So some people are getting good results. What's the difference? It's probably the patient ultimately, because if you're using the same protocol, you're using it, they're using, and they're getting a good result. But you also, as I said in the talk, that might be their 10% top results, and the other 90% didn't respond anywhere near as well as that. And we don't know that. But I think dose-related response in hair is important, and that's going to come up. So I do think this new protocol that TLAB have developed, it will hopefully answer that question.
Just practically for you, Mr. Mahmood, you would bring the patient in for consultation, get the blood work done in the consultation, and then call them back in for an examine or an exosome procedure then at a later date.
I mean, for my hair consults are very medical.
Yeah.
I think aesthetic treatments, if somebody comes with a facial improvement, they're a bit less medical. I tend to still give them all the science, but actually you can deliver a good result for facial rejuvenation in somebody with decent skin fairly easily, in my view. It's not that difficult to generate an improvement in them. But for hair, they're a different client base. You have to know their genetics, you have to know their medical history, you have to know what their bloods are, you have to know what their hormonal levels are, you need to know what their nutrient levels are. And so I usually try to bring them into what we call a hair protocol. And that is £1,000 upfront protocol, because we do genetics, bloods, nutrient analysis, and then we go ahead with the treatment. So we are pushing them in that direction, saying if you really want the best results, we need to know all of this to tie it all together, to then know what supplements you might need, what medicines work for you, because the epigenetic tests actually give you an indication of whether minoxidil will work or won't work, finasteride should be used for them or not used for them, etc. It actually gives you a signal of what is effective and not effective based on their genome. And obviously, if their vitamin D levels are through the floor, a lot of what you do may not work.
Yeah.
So knowing simple things like that, even if it's point of care, I think you have to have a protocol. For hair, I explain that to them, saying that we're shooting in the dark if you don't let us do all these tests. If they really can't afford them, then fine. Or they've had a good response before, then you say, fine, okay, let's just crack on and do it. But if they will let us or they'll listen, then we try to optimize them and check everything beforehand.
Question there: can I send people to you for these tests?
Well, yeah, absolutely, yeah.
Yeah.
But
The photos,
I can
Jill,
introduce
are a
you
single
that.
examine treatment. Yeah, that's correct. They're a single examine treatment
I
from
think,
the current protocol, not the updated protocol.
yeah, I think one of them may have been the updated protocol, but
Oh, I see. Okay.
I think the first two were the standard, were the current protocol.
Yeah.
There was a question from Gunaratram. If you build up patients about the benefits of PRP, how do you bring exosomes into your practice? Oh, well, this, if you're using PRP exosomes, I think it's just about saying it's just a case of saying to them that we've got a treatment that may be more direct, potentially higher potency, and you may need less sessions. Because we're getting the end product of the PRP without any dilution, less diffusion, and a more direct response to the end organ delivered immediately. Because we know that with PRP, you will get a degree of diffusion, dilution, you'll lose some of the growth factors. That's where technique becomes important as well, depending on where you place the PRP, etc. I see Kieran's message as well about testosterone levels. Yes, I have a very low threshold for doing well woman, well man testing, which includes hormonal tests on most of these patients. And he's done 15 patients, which is a decent number. I mean, you shouldn't have done 15 and seen no response. But it depends how long that response is. 3 months is probably your minimum. And again, are you doing trichograms or is it just before and after pictures, which can be a bit challenging to detect? Because, as I say to my patients, a 40% improvement, which is the maximum. If you look at the PRP literature, you're expecting improvements from around 18% up to 45%. What gives the difference? When you separate that literature, you actually find the higher dose treatments are in that 35, 40, 45% bracket. And if you're expecting 40%, what's 40% of nothing? It's nothing, right? So it sort of depends on the patient, what you're dealing with, how thin they are. All those things matter. And I think just recording diligently what you do as well allows you to analyze your results properly. I can see Kieran says he's been doing it for 6 months. So yeah, you'd expect to see some sort of response at 6 months, certainly. So all I can say is, yeah,
It's most likely the fixed angle centrifuge.
yeah. So it's knowing what you are injecting is important as well. I mean, the MHRA did a little exercise where they came out and did a review. I remember speaking to one of their senior inspectors when I was lecturing at the British Orthopedic Association, and they view on PRP, never mind exosome products, because even with exosomes, when you're doing them, I mean, people are quite cautious, and when people ask me, well, the kind of questions you guys asked around regulation, you've got to be a little bit careful because you may be able to say you're using an exosome product now. But in 6 months, you might find the regulator says you can't. But in effect, what are you actually using? You're actually just using a derivative of PRP. So if you just say we've got an enhanced PRP or PRP advanced therapy, this nonsense came out about PRF a few years ago where they called it an advanced PRP, even though it was an old PRP that had been around for 20 years. The injectable PRFs were bought along with the same sort of thought process. It's the same. I mean, so in some environments where people are worried, I've just said to them, just call it an advanced PRP treatment or an activated PRP treatment, so PRP-A or something, or PRP-EXO. You can actually still call it a PRP treatment that you've just changed very slightly. Because as I said, the regulators' view on PRPs, if you actually tell them what it does, they think this is a drug because they say, oh, so it changes inflammation. You inject it into the patient and it has an immune modulatory response. This is a drug. So you're now telling us you're manufacturing a point of care drug and delivering it into a patient. And when we ask you what's in it, you say you don't know. As a doctor, as a regulator, their immediately alarm bells start ringing, thinking, "What the hell are these doctors doing?" So it starts to become a little bit challenging, and that's the environment we're trying to fight against really at the moment. That they're restricting us because what they inevitably do is they push you towards using inferior, poorer treatments that are less natural, less biological. Because those are the standard of care. The standard of care is really low, but it's the standard of care. Everyone accepts that low standard of care. When you're trying to push the boundary and escalate that standard of care, you can actually find yourself with regulators sort of breathing down your throat or getting threatening letters occasionally, etc. And that's what people are worried about if they say they're doing exosomal treatments. As I said, some clinics are just calling it advanced PRP. But it's not a one size fits all approach, unfortunately, as we all know in medicine. And we're all learning. As I said, I changed my own PRP protocol every 3 months. Last year, in 2025, it's changed 3 times. Dose, the type of PRP I use, the bioformulation of it, whether I have monocytes in it or leukocytes in it, that's changed 3 times this year. And that's just because as the data comes out, the research comes out, some patients I activate, some patients I don't activate. And this is just off the back of, once you've done it a few thousand times, you start to pick up clues, whether you call that clinical acumen, or not, is an unknown. But I found that by slowly tweaking my own practice and recording what I'm doing, my results are going from sort of 70% of patients being happy to 80% of patients being happy to now 90% of patients being happy. So I'm slowly getting better. But I still know there's a 10, 20% that I just don't know what's going to happen to them, because I know there are non-responders still in my practice.
Can you tell me again when should do red light and for how long, as I do skin PRP for skin as well as hair? I'm not quite sure.
So if you look at the right wavelengths for red light for hair, I mean, what I actually do is I use an anti-inflammatory wavelength immediately post-treatment, and then I use a booster afterwards. And if the patient's willing to come back weekly, they should come back weekly for 4 to 6 weeks. For hair and face, put it on their face, put it on their hair. And if you've got one of those larger devices that will fit over everything, even better. So immediately post-treatment, I do it. And then we offer them a session. So again, it's another upsell, right? But you can offer them sessions, 4 sessions, 6 sessions afterwards, where they come in once or twice a week and they have a top up of the red light therapy.
Yeah, I've seen a lot of questions come in. Just in general, we get a lot of questions about combining exosomes with other types of therapies. We've had questions about laser therapies for treating scar tissue,
Yep.
all sorts.
And the simple answer is there's actually plenty of data if you look at the PRP data, and also 2 of the studies I mentioned were combining microneedling, were combining laser, CO2 and picosecond, and showing it enhances the effects. So with picosecond, there was a bit more of a wavy improvement. It wasn't quite as pronounced. In the discussion of that paper, if you actually read it, it says that with picosecond, they get some, because it punches into the skin, they can actually get a little bit of redness and bleeding, and that may prevent any internalization necessarily of the. But that may be the technique of pico, because I know pico doesn't always create bleeding, but I'm not a laser expert. I have to tell you that. So I'm sure there are laser experts who will say to me, "What are you talking about? Picosecond is always amazing." But I've got picosecond zealots who I do know would tell me that it's amazing for everything. As it create, as a simple term I've been told is it just punches. It delivers a tiny amount of energy because it's such a short burst, but it creates a hole in the skin. Whatever you put on the skin, it's like a sponge. Everything goes in. That's how I've had it described. And but interestingly, picosecond with exosome didn't work as well as CO2 with exosome or needling with exosome in that Mayo Clinic study.
Yeah, so just a question in from Dr. Tracy there because the microphone isn't working. So we have to look at the difference between PRP and exosomes. PRP is mostly just growth hormones. Exosomes are different. Red light upregulates cell receptors, exosome acceptance, and internalization.
Yep. I mean, I think ultimately with we talk about longevity medicine, we talk about cellular upregulation. This is actually, if you broke it down into one thing, it's about energy medicine. If such a thing exists, if you can change the energy the cell operates at, the wavelengths it operates at, and that's what red light does. I'm a believer in red light therapy, Patrick. So I think I'm trying to get one of those posh full body beds into my clinic at some point. There's lots of very good data on it. If you look at Thor Medicine's data, I ran the British Regenerative Medicine Conference about 2 years ago here. It was a multidisciplinary meeting, and the evidence behind it is immense. It's just using the right way and using the right wavelengths. There are a lot of copycat companies out there, and I think the way the energy is delivered matters. The photons matter, and it's like anything, the nuance actually matters. So just going out and buying something that costs £99 on Amazon is probably not going to give you the result you want, but it is available. There are lots of companies out there are selling red light for a couple of £100.
I think we can hear you through your phone there, Patrick.
Can you hear me? Yeah, because
yes, just now, yeah.
well, listen, Ansar, wonderful lecture. Thanks for that. And there's no doubt about it, photobiomodulation is the way to go. When we started doing regenerative medicine with hair, probably 20 years ago now, we always used red light. Then when the nurses started doing it, it dropped off a bit. But I totally agree with you also to prepare the patient beforehand with red light. We do that now even with doing laser ablation of the face, because it will reduce the inflammation in the cells before they're actually hit by the laser. So you can use it before and afterwards. We've tended to I suppose, not use it as much as we made this more a commercial entity rather than a sort of wound repair thing. So we've a couple of clinics, the nurses have been doing it, and we've dropped the red light a bit, but I think we'll reintroduce it again, to be honest. We do for wound repair and we do for lasers, but for and we do for skin rejuvenation, but we dropped it a bit for hair. I don't know why, but
Yeah, I mean,
yeah.
I mean, you find the same. I mean, my sort of device, I had a Dermalux and I had a Saluma, and they got parked, and I've just pulled them back out now because I'm using them more.
Yeah, that sort of thing, yeah.
Yeah, and I see the message from Kieran as well around radio frequency, and the answer is yes. I'm not a big fan of radio frequency microneedling, I have to say. But that I'm not. I also have to admit my biases. I'm very biologically and regenerative driven. I don't like high energy devices because the way most radio frequency devices work is fibrosis generators. They are fibrosis generators, and you have to be careful with the nuance of how you use them. There's a lot of harm being caused by overzealous radio frequency devices. If you go to the complications conferences, I think it's going to be one of those modalities that the energy is going up. The way people are using them is to generate a better result, but it does work, right? But what you'll find is 2, 3 years, 5 years downstream, you'll find a lot of fibrosis in people's skin from having radio frequency too often or having too high an energy used too often. So again, you're stacking fibrosis, and over the years, that will come back to haunt you. If you think it gives you an enhanced effect, and you keep the energy low, and you give enough of an interval between treatments, you'll usually be fine. But as I said, what tends to happen is there is a escalatory element to this, is that each device that comes out has a bit more energy and a bit more energy and a bit more energy, or the needles go a bit deeper, which again generates a bit more fibrosis and stimulatory response. And so I always find that these devices create an escalation in the industry as large, and the next one will come out with bigger needles and more energy, et cetera, et cetera. And so, yeah, so I like radio frequency in principle, but we're still a bit old fashioned. We just use RF that generates a bit of heat. Gets the skin temperature up to about 40 degrees, 41 degrees, and it tops out. And that's been well studied for 15, 20 years, and we know it works, and it doesn't generate fibrosis. So the needle was delivering energy deep into the dermis. I'm quite uncomfortable with. I'm not a fan of that.
Right. So that was that was wonderful. Really appreciate your time and your lecture, Mr. Mahmood. I think we will, unless there are any other questions, we might just wrap it up there. So
Great. Thank you for the questions, and good to see you again, Patrick.
Absolutely, Ansar. Thanks for everything. That was wonderful. Yeah.
You're welcome. Thanks, guys.
Super.
Take care. And,
so thanks everybody for attending.
Yeah, everything is evolving all the time, so just stay up to date.
Yeah, great. Cheers.
Take care.
Cheers.
Take care. Bye.